So today we're going to go over pain pathways. And, you know, this is a lecture that everybody gets in your anesthesia program. And a lot of people tell me that when I give the lecture, they're like, I feel like you explained in 5 minutes what people struggle to explain in three, in 3 hours. So we'll try to keep it simple. There are some terms that you may not have heard of before. I'll try to break down those terms to the simplest form. People often say that when I give this lecture, it is a little bit more simple than when they've gotten the lecture in their class. And for those of you that have had this lecture before, this will be a nice overview, maybe a review for your C exam or for your boards. Everyone can see the slides okay? All right. And one more time, if you had not uh, gotten the slides, because maybe you joined after I shared them in the chat, I'm going to share the link one more time here, and you should be able to access the slides and download them directly from the Canvas site. Cool. Let me keep the chat up so I can monitor it. For this talk today, we're going to thank you. Thank you so much. Um, for today, we're going to go over a lot of the anatomical structures, the neural structures that make up the pain pathway. We're going to talk a little bit about chronic pain, how chronic pain occurs, how this transition from acute to chronic pain occurs, and very briefly touch on some mechanisms of action of some non-opioid agents. We're actually going to cover this in a lot more detail in our next webinar. So because I'll be with Sachi in June, we're going to skip June, but July's webinar is going to be all about non-opioid pharmacology. So the end of July. Just keep that in mind. Last Wednesday in July. But for this lecture, we're going to talk a lot about the anatomical structures of what makes up just physiologic pain. Yep. Physiologic pain, chronic pain. Okay, so what is pain? There is this international association called IASP. It's the International Association for the Study of Pain that determines all of these definitions. So they define pain as an unpleasant sensory or an emotional experience that's associated with actual or potential tissue damage, which is kind of interesting because tissue damage doesn't have to occur in order for you to experience pain, right? And when you have acute pain, this is usually a protective mechanism, right? Because when you have pain, you often you might shield that area from more injury. You might guard that area, and it causes you to seek out care. It's actually the number one reason why people go to the ER because something hurts, right? It makes us go get help, right? It's a protective function. But as pain transitions to something that's a little bit more chronic, it no longer has or serves a protective function and becomes more of a disease state. And we'll get into that in a little bit and what that actually means. We often use these terms interchangeably when we say pain or we say nociception, but they are very distinct. So nociception is when the nociceptor is stimulated and that action potential travels from the periphery into the spinal cord and up to that brain. That whole process is nociception, that signal that's being transmitted. When it reaches the brain, your brain then decides and interprets what that signal is and interprets that signal as unpleasant. And that experience is what we call pain, right? But everything up to that point is actually not pain. And this is where it gets kind of confusing, especially for patients that are under anesthesia, right? Because patients that are under anesthesia aren't technically experiencing pain because they're anesthetized, but they're experiencing nociception. And so their body's responding to it by an increase in heart rate and blood pressure. And that's actually what we're treating. Okay. Because sometimes maybe our MAC values aren't high enough to block some of that noxious stimuli that's going up to the spinal cord and up to the brain. So we might sometimes use these words interchangeably, but just remember that these terms are pretty distinct, pain and nociception. We talk about chronic pain. What makes something chronic pain? It's usually pain that is lasting more than 6 months. And a lot of people are affected by chronic pain. I'm sure there are people in the audience right now that have chronic pain, and it's about 20 a little over 20% of people in the United States that experience some kind of chronic pain condition. Lots of different mechanisms, etiologies, a lot of environmental factors that go into somebody that develops chronic pain. So we'll talk about that in the second part of this lecture. Other types of terms that you might hear throughout this lecture: allodynia, that's when you have pain to something that usually is not supposed to provoke pain. For example, people that have neuropathic pain, they might have a painful sensation when their clothes rub up against their skin. That's not something that's supposed to cause pain, but that's causing pain for them. Or if they brush their hair. So that would be allodynia. Hyperalgesia is pain from a stimuli that does normally provoke pain. It's just going to be a little bit more painful in that person than what it would normally would be. So it's like the response doesn't match the stimuli. If somebody pokes, person A with a needle, and that usually causes a 3 out of 10 pain, for somebody that has a hyperalgesia, it might cause 8 out of 10 pain, right? It's an increased response. Some of these other terms you can read on your own if you download the slides. There are three main categories of pain. One that we're very familiar with, which is nociceptive pain. That's the pain that arises when you stimulate the nociceptors. So it's damage to non-neural tissues like your muscles, your joints, your skin. And this is the typical pain we think of all the time when we cause trauma to our tissues, surgery, osteoarthritis. These are types of nociceptive pain. Neuropathic pain is a lot different. So this is when there's damage to the neuron itself. So something is going on with the somatosensory nervous system, or we call this nerve pain. So the neuron is damaged, and lots of diseases cause this, like diabetic peripheral neuropathy, trigeminal neuralgia, sciatica, any type of, nerve pain, damage to the neuron. Nociplastic pain is a new pain category, and we've put a lot of other diseases in this category that don't fit into these other two categories. So if it's not nociceptive and it's not neuropathic, we call it nociplastic. And usually there really isn't any clear evidence that there's any kind of tissue damage, but people are experiencing these symptoms. So, for example, fibromyalgia, right? We don't see any tissue damage anywhere, but people are experiencing diffuse body pain in their muscles and their joints. IBS is another example, and complex regional pain syndrome, previously called RSD. So these are all types of nociplastic pain, not very well understood, very, very difficult to diagnose, and often times dismissed in a lot of patients too, which is a shame. Lots of different treatment options for pain, as we know. We'd like to focus on our non-opioid medications, a lot of antidepressants, anticonvulsants like gabapentinoids, NMDA antagonists like ketamine. We have all of our opioids, our oral and our IV methadone, lots of short and long-term therapies, non-pharmacological therapies, so our TENS therapies, physical therapy, OMT, which is osteopathic manipulative therapy and acupuncture, and a lot of physiotherapy as well. And, I will say that a lot of the pain experience is in our brains, right? But they're not made up. They still exist. People are still experiencing those things. But physiotherapy and psychotherapy can help with these pain disorders, especially from really complex pain disorders that have like, for example, phantom limb pain. Have you heard of phantom limb pain? Mirrotherapy is a type of psychotherapy that they use with people that have phantom limb pain because they're having pain in an arm or a leg that doesn't exist. So they use the mirror to put up against their existing arm to kind of trick their brain into thinking that their other arm exists, and then they slowly help them dissociate their brain from that arm. And so it's a way to actually treat their pain by going through this like psychotherapy, which is really interesting and works for some people. So let's go through the pain pathway, some of the anatomy, and it's gonna get real dense. But like I said, we're gonna take it slow. We're gonna build our way up to it. Okay. So this is a pretty simple picture of what the pain pathway looks like. And there are four main stages when it comes to pain transmission and pain modulation. Okay, so I have one, two, three, four. The first one is transduction. That's when your body takes some kind of stimuli and turns that stimuli into an action potential. Okay. And this is normally done by nociceptors that are coupled with ion channels. And those ion channels are usually sodium potassium channels. We're going to go through that in a lot more detail. So that's transduction, taking a stimuli, whether that is mechanical pressure, a thermal sensation like hot or cold, some kind of chemical stimuli like an acid burn, and turns that into an action potential. Stage two is transmission. So that's when that action potential moves from the periphery and goes to the central nervous system. So from the periphery to the spinal cord and goes up the spinal cord to the thalamus. And the thalamus is like a relay center in the brain, takes those signals and just shoots those to a lot of different areas in the brain that control our awareness and unpleasantness of that signal. Okay, so that's transmission. At the same time as that signal is going up to the brain, branches from those neurons that going up connect with neurons in the brainstem to go back down. It's kind of interesting. It's like going in this big loop. So even though this blue dot is over here in the brain, really it should be here in the brainstem. So as soon as this neuron goes up, it shoots branches off to connect with neurons that go down, back down to the spinal cord to what we call attenuate pain or decrease pain. Because your brain doesn't want the pain to be so out of control, it tries very carefully to downregulate it or decrease it so that it is under control. So this stage is called modulation. And this is a way to inhibit the pain signaling. We're going to go through all the chemical structures and that's happening at this area here. So that's modulation, a way to decrease pain. And last is your perception. So that's when those pain signals are going to areas of your brain like the somatosensory cortex, the anterior cingulate cortex, other parts of the limbic system and prefrontal cortex that all take everything into consideration, whether it's your environment, your past experiences, cultural conditioning, everything to bring it all together to give you the experience of pain, whatever you experience. Okay, so those are the four stages. So we're going to break down each one of those stages. Now, that last picture was pretty simple, right? But in reality, if you kind of break down a lot of the pathways that are involved in the pain signaling, it's a lot. It's a lot. It's really complex. There's lots of receptors involved, lots of neurotransmitters involved. This is just at the periphery here. You can see all these different pathways. There's an area that we're not going to talk about a whole lot that's really involved, which is the dorsal root ganglia. This is the cell body of that first order neuron. Lots of chemicals going on here. The connection between the first order neuron, the second order neuron, so many pathways, and so on and so forth. So just keep in mind that, even though this lecture will seem kind of dense, it's still a pretty broad overview as to like what's actually going on. So just keep that in mind. There's always something, there's always another layer, right? There's always something more to learn. So, when you come to the ascending pathway, so that's the pathway that goes up to the brain, there are three neurons involved in order to get you from the periphery to the brain. And we call those the first order, the second order, and the third order neurons. Not very creative with the names, which is good because it's easy to memorize. So the first order neuron is going to take you from the periphery all the way to the dorsal horn of the spinal cord right here. That's your first order. Your second order is going to take you from that point up to the thalamus. And then the third order neuron is going to take you from the thalamus to whatever region in the brain. So we're going to first focus on that first order neuron here. This is a graphic that I made for a paper that is in review right now. Kind of gives you a simple overview of the ascending pathway. So this is the red, And then that descending pathway, remember when I said there's always branches that break off in the brain stem that connect with the descending pathway, which go back down to that spot here in the spinal cord. So we're zooming in on this spot here, and that's this picture right here. So you can see these um, neurons here that say serotonergic and noradrenergic. As the name suggests, it's going to release neurotransmitters of serotonin, and noradrenergic would be norepinephrine. And then there's going to be this interneuron here that is going to release GABA and endorphins, which are inhibitory. So we're going to go through that in a lot more detail in a little bit. So that's this picture zoomed in here, the different neurotransmitters and receptors that are involved. Now, the ascending pathway is, all right, I'm going to skip to the next one. Okay, so let's start with the ascending path in the very beginning with the nociceptors. Now, there's lots of different stimuli that can occur. Like I said, thermal, mechanical, chemical, and that's going to trigger these action potentials to occur. Now, when it comes to nerves that are in your skin, there are different types of neurons that have different endings here. You could see these sensory cells, these encapsulated cells here that are for pressure. But when it comes to nociceptors, they're on free nerve endings. So there isn't anything special at the end. They're just called free nerve endings here. They're very unspecialized. And the type of neuron that is used for pain neurons is called a pseudo unipolar neuron, meaning that the cell body is going to be sticking out the side here. Versus if you think of like a motor neuron is going to have a big cell body that's kind of at the end by the dendrites. But a sensory neuron is a pseudo unipolar neuron, so you have a long axon with the cell body kind of in the middle. Now, the nociceptors, there are different types of nociceptors. A lot of these are ion channels, and a lot of them are part of this TRP family. So TRP V1, TRP V4, TRP A1. A lot of these are stimulated by different types of chemicals. If you've heard of TRP V1 before, that's the nociceptor that capsaicin stimulates. So capsaicin is like the spicy component of hot peppers. That's how we've been able to study the TRP V1 receptor. So it's kind of interesting because like we get the sensation of heat when capsaicin triggers the TRP V1 receptor, and that gets relayed to our brain as pain, which is kind of interesting. Other types of nociceptors I'll call the piezo-2, which I think is stimulated by ATP. ASIC3, these are acid sensing ion channels. So they're all different types of ion channels. They all get stimulated by different types of chemicals or heat, cold, um, or they're some kind of like mechanosensor. So they can feel like pressure, trauma, that kind of thing. And a lot of these nociceptors are then coupled to these ion channels here. And we're going to talk about that in the next slide. So these ion channels here, you could see the nociceptors are on the free nerve ending, like TRPV1, and they're coupled to these ion channels here, which are your sodium and potassium channels, and very specific ones. I'm going to really point some of these out because some of the new drugs that just got released work on these channels here. So the NAV, so NAV 1.8 and NAV 1.7, these are really important. We just came out with some drugs that modulate these NAV ion channels so that the action potential never even gets sent to the spinal cord. It just stops right here. We would block these sodium channels. So the nociceptor gets stimulated. It then allows sodium to rush into the neuron, and then that's going to stimulate that action potential to occur and shoot down the axon. And like I said, a lot of these are discovered and studied using chemicals like capsaicin, and that's how we discovered a lot of these nociceptors. So the graded potentials, meaning that when these are stimulated, the graded potentials are like electrical signals. They converge, they kind of add up, and then that causes these to open, and those action potentials to build. The neuron will depolarize and send that action potential down the neuron. And we've studied these sodium channels pretty extensively. We've actually mutated them. And when we mutate them, we basically, when we lose the function of these channels, the body is not able to detect any noxious stimuli at all. So the action potential, the nociception is really dependent on these channels. And that's how we were like thinking, okay, if we develop a therapeutic to block these channels, then you are not going to experience pain. And so there's a medication that just came out recently that I think actually this class of medications is going to completely replace drugs like fentanyl for acute pain because they work so well. Because the body is just not able to ever send that action potential to the spinal cord. So we'll talk about that in the medication section. I'll talk a little bit about acute inflammation. It's not its own category of pain because inflammation is a part of literally every type of pain disorder that's out there. And we understand inflammation pretty well. When inflammation occurs, when tissue injury occurs, inflammation is supposed to increase blood flow to the area so that healing can occur. And there's lots of chemical mediators that are released, like prostaglandins, serotonin, histamine, and ATP, that are going to bring, white blood cells and other types of immune cells to the area to help wound healing. What it does, though, is a lot of these chemicals decrease the firing threshold of those nociceptors. So it makes that area a lot more sensitive. And of course, it's swollen, there's lots of fluid there. But if inflammation goes on for a long time, those nociceptors can actually change the way that they function so that they fire at a much lower threshold than what they normally would. And sometimes that can turn into a chronic pain disorder if those nociceptors never get an opportunity to kind of reset and go back to their normal state. So inflammation is good in short term. Inflammation is bad for long term because it causes our neurons to kind of like physically permanently change, so that you always have sensitivity and pain. Same thing that I said earlier, just another graphic showing all of these kind of like chemical mediators and different types of receptors and nociceptors that are involved. So first order neurons. Now we know that the neurons are categorized into this A, B, and C classification system based off of how big they are and if they're myelinated or unmyelinated. So for those who have not been introduced to this topic before, neurons are categorized into A fibers, which are further subcategorized into A alpha, A beta, A delta, and A gamma. And then there's B fibers, and then there's C fibers. A fibers and fibers are myelinated, they're usually the biggest ones. C fibers are unmyelinated, and they are the smallest in diameter. And based on their myelination and how big or small they are, determines how fast that action potential moves down the neuron. So when it comes to pain neurons, the main categories for pain neurons are A delta and C fibers. Your A delta are your bigger myelinated neurons, and they usually transmit fast pain or sharp pain. That's further subdivided into two different types, so type 1 and type 2. Type 1 is more sensitive to mechanical and chemical. Type 2 is more sensitive to thermal. C fibers are smaller, they're unmyelinated, and so they transmit that action potential a lot slower. And so they usually transmit what we call second pain, which is slow, dull, or burning pain. And they also transmit other sensations too, like itching. The other types of fibers do not transmit pain signals. So the A alpha fibers are typically your motor neurons. Your A beta fibers are usually your touch and pressure fibers. Even though they don't transmit pain, they are a part of the pain pathway indirectly. And we're going to talk about that in a little bit. Have you ever noticed that if you like fall and bump your knee, you're instinctively going to like rub your knee and it makes it feel better? Or if you're pushing propofol in the OR and the patient's saying that their arm is burning, what do we instinctively do? Start like rubbing their arm, right? There is a mechanism behind that, and that is your A beta fibers. And because the A beta fibers are bigger than your A delta fibers, they're faster. And because they're faster, they actually get to the spinal cord before the A delta neurons and do something really interesting in the spinal cord in order to decrease pain. Okay. It's part of the gate control theory. So even though they don't transmit pain, they're involved in modulating pain too. So that's your first order neurons. Like I said, these are pseudo unipolar neurons. So that means the shape of it is there's not one big, large cell body that's at the end by the dendrites, but the cell body is actually somewhere in the middle. And these cell bodies collect in one region of the CNS called the dorsal root ganglia. So you have, if you imagine your first order neuron comes in like this and connects into the spinal cord here, there's actually a bulge right here, right outside the spinal cord here. And that's where all of these cell bodies collect. That's the dorsal root ganglia. The dorsal root ganglia is a very interesting and understudied area of the pain pathway. There's a lot of chemical signaling that happens here that we don't talk about enough. In the science world, we talk about the dorsal root ganglia enough, but a lot, but we don't talk about it a lot in the clinical world. But just know that it exists and that there's a lot of science being done to try to understand kind of what's happening here at the cell body of the neuron. So the first order neuron here. You have your nociceptors, your sodium channels, and then your action potential transmission, and that's going to lead into the spinal cord. Now, when you look at the spinal cord, the neurons that are going in and out of it, so it's this dorsal part here where signals are going into the spinal cord. That's where a lot of your sensory is going into. And it's the ventral area here is where signals are leaving the spinal cord. So that's usually your motor tracks are going to come out this ventral side. So we're going to come in this dorsal side and enter this horn here of the spinal cord. So let's talk about the dorsal horn of the spinal cord. So you see your C fibers and your A delta fibers that are entering the dorsal horn of the spinal cord. Now, this area of the spinal cord, which is all your gray matter, which is what makes up this little butterfly here, all this other stuff is white matter. The gray matter here is broken up into regions, and we call those segments rexed lamina. And there's actually 10 of them, 1 through 10. So we start at the top, 1, 2, 3, 4, 5, 6, so on and so forth, and get down to 10. The most important ones are going to be from 1 through 5. That's where all the action's occurring. So this is the region in which the first order neuron is going to synapse with the second order neuron. And it's mostly in rexed lamina 1, 2, and 5. Now, rexed lamina 2 is really interesting, which is this second purple bar right here. It's an area that a lot of that, when I talked about those descending pathways or decreasing pain, modulating pain, a lot of that is happening in rexed lamina 2. And so it's given a special name called the substantia gelatinosa. I don't know why I just love saying that word, substantia gelatinosa. It's an often like tested area, which area the pain pathways or pain modulation occurring, rex lamina 2 or substantia gelatinosa. But essentially what that means is that rex lamina 2 is very abundant with these very short neurons called interneurons. That's this purple that's right here. And the interneuron is an inhibitory neuron. That's what's going to release a lot of your endogenous endorphins and enkephalins and dynorphins, which are your chemicals that are going to decrease pain signaling, right? They're inhibitory. And that's where a lot of our exogenous opioids that we deliver are going to work because there's lots of pain receptors there, mu receptors, delta, kappa. Other chemicals that it releases are cannabinoids, so our endogenous cannabinoid system, and also some GABA too. There's GABAergic neurons there. So we'll talk about what's happening there at the chemical level. So essentially, you see this connection between the first order neuron and the second order neuron, and this interneuron is kind of like a gatekeeper. It's going to kind of decide how much of that signaling is going to go through or not go through. Kind of helps create some homeostasis, I guess, not cause that pain signaling to be so intense. Try to control it a little bit. When it comes to the transmission of pain from the first order neuron to the second order neuron, there are several excitatory neurotransmitters that are involved. The main one is glutamate. Glutamate is all over your central nervous system. It is the most abundant neurotransmitter. It's an excitatory neurotransmitter, and there are several receptors that respond to glutamate that transmit pain. The one that we talk about all the time is NMDA because we give ketamine and ketamine blocks NMDA, but there are others too that you might not be aware of. Other ion channels are AMPA receptors, AMPA, it's very similar to NMDA, kainate receptors, and then there's also these metabotropic glutamate receptors. There's about 8 of those. The main difference is that AMPA, NMDA, and kainate receptors are ion channels. The metabotropic glutamate receptor channels, as the name suggests, is a G protein coupled receptor. But they all respond to glutamate and they all transmit pain. Another neurotransmitter would be substance P, and the receptor would be neurokinin receptors. Another excitatory neurotransmitter would be calcitonin gene-related peptide or CGRP, and you could see the receptors here are CLR and RAMP1 are the receptors for that. Of course, this slide's very busy, but you can see here there's cannabinoid receptors as well, so CB1, CB2, and the endogenous cannabinoids are 2-AG and AEA. This is where, THC is going to work to help decrease pain. And CBD, we're not quite sure exactly how CBD works, but what we think is happening is CBD prevents the breakdown of 2-AG and AEA, so it kind of works indirectly, which is why it doesn't work great for everybody, for a lot of people. But that's the current theory of how CBD works to help with pain. So that's the dorsal horn of the spinal cord. Now, what's interesting is that a lot of neurons that enter the spinal cord and travel up the brain, they travel up the same side as where it enters. So if you have another type of sensory neuron like pressure or, deep pressure or touch, it's going to enter and say it's coming in from the left side. It's going to enter the left side and then travel up the left side. But for pain and temperature neurons, they actually cross over to the contralateral side. So if they enter from the left side, they're going to cross over this midline here and go up the right side. Other neurons that carry other type of signaling, they cross over higher up or they cross over in the thalamus. But when it comes to pain and temperature, they cross over at the level in which it enters the spinal cord and then goes up that track. And the main track that it goes up is the lateral spinothalamic track, is what that track is called here. So it crosses over all the way to the other side and goes up this lateral spinothalamic track, and that's what's going to carry that pain signal up to the thalamus. This is just important, like FYI. Understanding that pain and temperature crosses over to the contralateral side, but other types of neurons do not, which such as 2-point discrimination, vibration, proprioception stays on the same side, really helps you in trying to diagnose a spinal cord injury. So just keep that in mind. When you're trying to diagnose the level of the spinal cord injury, just really understanding that pain and temperature crosses, but other types of sensations do not help you when trying to discover where that lesion is at and then what side of the spinal cord is affected, whether it's the right or the left side or the central or the kind of outer side of the spinal cord when it comes to those types of questions. I don't have a lot of time to get deeply into that, but just keep that in mind that, understanding what crosses and what doesn't cross. So when it comes to traveling up the spinal cord now. So we're going all the way up to the thalamus. Like I said, the thalamus is like a relay center, and that then shoots these third order neurons to different parts of the brain. And there's lots of brain regions that are involved in your sensation of pain. But the first area is going to be the somatosensory cortex. Now, the somatosensory cortex is part of the parietal lobe. You could kind of see this strip here. The somatosensory cortex would be the purple one here. The maroon looking one here is usually the motor cortex, so they're pretty close to one another. Somatosensory cortex is really interesting because all the somatosensory cortex does is it tells you that you have some kind of physical stimuli that's occurring. So it's the first area that says, "Hey, I'm having a physical sensation that's happening in a certain area of my body." And I think we understand what the homunculus is, right? It's, the certain parts of your body, like your face and your tongue is a lot more sensitive. There's a lot more neurons there, so they occupy a larger part of your brain, this outer part of your brain here, whereas like your limbs and your feet don't have as many sensations or neurons there, so it doesn't occupy as big of a region of the brain here. So all it's really telling you is that, hey, I'm having a stimuli in my mouth, or I'm having stimuli in my elbow, or whatever. It just pinpoints it. But it doesn't do anything to interpret whether it's unpleasant or not. Other parts of your brain do that. Okay, so we're gonna talk about that in just a second. Somatosensory cortex just says, I am experiencing something acute and physical. Now, brain regions that are involved in your whole experience of unpleasantness, you deciding that whatever sensation you just had, I do not like it. And this is what gives you the experience of quote unquote pain, right? So, as the same time as it's shooting off third order neurons to the somatosensory cortex, it's also shooting off third order neurons to other parts of your brain as well, especially regions involved in your limbic system. And as we know, our limbic system is really this part of the brain that's involved with our emotional responses. These are very, how do I want to say it, evolutionarily old systems that are meant to keep you alive and help you avoid things that are unpleasant. And we'll go through each one of these sections here. So, the first one, anterior cingulate cortex. This is a little bit more in your prefrontal cortex. This is what gives you that sensation of like, I don't like whatever just happened, right? It's our affective pain and our emotional part of the pain experience. Prefrontal cortex is part of your perception. Insula cortex here, it connects your ascending and your descending systems. So when we talk about those descending pathways, that starts also with the insula. And then we get into our limbic system. So our hippocampus is really interesting because our hippocampus is really involved in learning and memory. So if we have past experiences of bad pain or trauma, that informs our current experience. Our amygdala is involved in fear and anxiety. Your hypothalamus is involved in your autonomic nervous system response. So your heart rate and your blood pressure going up, and your basal ganglia as well, all involved in this like emotional and behavioral responses that we have to pain. And that all of this together gives us the our experience of having pain. It's really interesting. And that's why I call it the pain matrix, because it's not just a pathway. It really is this like massive matrix of neurons that inform our pain experience. I want to briefly go on a tangent and talk about referred pain, because I think referred pain is really interesting and a lot of us don't really understand why it occurs. So, what happens sometimes is when you have first order neurons that come from the viscera, like your organs, oftentimes they will share a second order neuron from some other part of your body, like your limbs, your skin, your muscles, or somewhere else. And because it's sharing the second order neuron with another part of your body, By the time that signal reaches your brain, it's actually not sure where that signal came from. It actually gets confused. I don't have an explanation as to why that sharing occurs, why it doesn't have its own second order neuron. I just know that the viscera and the other parts of your body, like your limbs or skin, can share that second order neuron. And so, because your brain is misinterpreting where exactly the signal is coming from, we have this experience of having referred pain. And that's why people, for example, men and women that have a heart attack have pain in their shoulder, their lower back, or other parts of their body because the brain is actually kind of confused as to where that signal is coming from, right? And that's why we're getting referred pain. Other organs, though, do have their own pathway. They actually don't cross over to the contralateral side. They actually stay on the same side and travel up this dorsal column here. So it's traveling up to the dorsal column into the brainstem and then crossing over. And this is really interesting too, because if somebody has chronic cancer pain in an organ, say they have a solid tumor in an organ and they're not able to get any pain relief, what we can do as a type of procedure is actually take a needle. You can see this picture here and actually stab the spinal cord with that needle and try to damage those tracks here. You could see that this part of the spinal cord has been damaged with a needle in order to, in a palliative setting, relieve that person's pain and try to damage those pain tracks. Okay. This isn't done very often, but sometimes done for people with intractable cancer pain. So just a couple of different types of pain pathways from the viscera that I think are kind of interesting to keep in mind, that the viscera sometimes behaves a little bit differently than other parts of our body. I'm not going to go. I guess I could talk about this. It's a little tangential as well. But okay. So you've probably, come to learn that there are people that develop chronic pain conditions, and a big portion of those people also have comorbid disorders like depression, anxiety, and substance use disorder. And why is that? Why is it that so many people with chronic pain develop substance use disorder or vice versa, or develop these, depression, anxiety? And the main reason is because there's a lot of overlap between the pathways that modulate those diseases and pathways that modulate pain. And I'll give you one example. So we talk about the reward pathway. The reward pathway is also a very old pathway that keeps us alive because it keeps us doing things um, like seeking out food, reproducing, and makes those things pleasurable so that we keep doing them to keep ourselves alive. And the two main regions that are involved in the reward pathway are the VTA, which is the ventral tegmental area, and that's an area that sits above on the top of the brainstem, and then the nucleus accumbens. And the nucleus accumbens is more in the prefrontal cortex. And this is a dopamine pathway, right? And what happens when you experience something pleasurable is that signals are sent to the nucleus accumbens to release dopamine, and we get that pleasurable sensation or euphoria, and we keep doing that thing, right? And this is also the part of the brain that's involved in habit formation. What does this have to do with pain? Well, dopamine actually gets released when you experience pain in order to balance out pain. So you have this extreme unpleasantness of having pain, but if your body releases a little bit of dopamine, then it actually brings you back to baseline. So it's not meant to cause euphoria or cause pleasure. It's just meant to bring you from a high unpleasantness back to an area of just like neutrality. Okay. So your brain does this all the time when you experience pain. But over time, if you keep having pain and transitioning to chronic pain, actually some permanent structural changes can occur in this area where your dopamine gets depleted over time. So you're no longer able to release a little bit of dopamine in order to decrease pain. You actually get to the point where you have so much pain that you swing the other way and you produce a state called anhedonia, which is your inability to experience any pleasurable sensations from anything at all in life. And so, because a lot of these pathways are involved in also anxiety and depression, people often will, with chronic pain, will develop these disorders. We can get into substance use disorder in a different lecture, but you can see that because these areas are also involved in substance use disorder, about 50% of people with substance use disorder also have a chronic pain condition. So there's a lot of overlap there. So that's the reward pathway. So let's now talk about the descending pathway. Now, we talked about the ascending pathway. We've gotten up to the brain, third order neurons, different parts of the brain. Now we're going to talk about this area here where you start to have some branching and then these descending pathways that come back down to decrease pain. Lots of big words here. I'm not going to really, you know, I don't think it's as important to like memorize these words or anything, but just know that they exist. There's the periventricular gray region. We know that our brain has different ventricles, like the lateral ventricles, third and fourth ventricles. And so all these little areas here are clusters of neurons. So this is a cluster of neurons that's around the ventricles. There's an aqueduct that connects the third and the fourth ventricle, like a little tunnel. And so there's a cluster of neurons around that aqueduct that we call the periaqueductal gray. So that's the PAG. The locus coeruleus, these are other areas of the brainstem. You could see here another cluster of neurons. A raphe magnus nucleus. There's a cluster, these different clusters here, and rostral ventral medulla down here. So these are different clusters throughout the brain where these neurons will begin. And there's two main types of neurons, the serotonergic neurons and the noradrenergic neurons. And as the name suggests, the neurotransmitters that they release are serotonin and norepinephrine. And so these neurons are going to travel all the way back down to the area of the spinal cord in which that pain signal is entering. Okay. And they're going to come down, they're going to release the serotonin and norepinephrine in order to stimulate the interneuron here. And what the interneuron is going to do is release inhibitory neurotransmitters in order to decrease pain signaling. This is why we can give antidepressants to people to treat pain, because what the antidepressants do is they block the reuptake of those neurotransmitters because these are serotonin, norepinephrine reuptake inhibitors. They block the reuptake of the neurotransmitter so that more of that neurotransmitter will accumulate in the synapse and stimulate these receptors, right? And so that's why, and when we give antidepressants to people that have pain conditions, they actually work really quickly, within a couple days. Whereas when you're treating them for depression, it takes several weeks of taking these antidepressants. So it's a completely different mechanism when treating pain. So that's how the SNRIs work. Give me 1 second. I have to say goodnight to my children who are bursting into my office real quick. Okay, sorry about that. Let me close the door. They complain when I have late night meetings, so I told them that they can start bursting into my office then if it bothers them. That's our compromise. Okay. All right. This is just a simple graphic of what I just explained about some of these descending pathways. All right. Um, yeah, this is just explaining again the different areas. So the locus coeruleus is mainly norepinephrine. Some of these areas here are mainly serotonin, but I think that we understand that well now. All right. Let's start honing in on this area called the substantia gelatinosa, which is Rex lamina 2. So we're releasing norepinephrine and serotonin. That's going to stimulate the inhibitory interneuron. And that inhibitory interneuron is going to release endorphins, uh, enkephalins, dynorphins, GABA, and cannabinoids. And this is going to decrease nociceptive signaling. And how does that occur? Well, there are three main types of opioid receptors. You have mu, you have delta, and kappa. And so when I say endorphins, enkephalins, and dynorphins, they're going to hit each one of these types of receptors here. Now, these receptors are G protein coupled receptors, and they do several things within the cell. Now, when it comes to ion channels like potassium and calcium, you think about the first order neuron and the second order neuron. So one is going to be a presynaptic neuron and one's going to be a postsynaptic neuron. Let me go back so I can really point this out here. You have your first order neuron that comes in, and then you have your synapse. So this neuron here is going to be your presynaptic neuron. This is going to be your postsynaptic neuron here. There's lots of calcium channels that are in the presynaptic neuron that's going to control the release of neurotransmitters. Okay. When the action potential comes down, it stimulates those calcium channels to open. Calcium rushes into the cell and causes signaling for those vesicles that are holding neurotransmitter to be dumped into the synapse. What mu receptors do, and some of these pain receptors do, is they block that calcium channel so that those excitatory neurotransmitters cannot be released. That's one way that opioid receptors work. The other way is that it opens potassium channels in the postsynaptic neuron. So you have your postsynaptic neuron here, which is very heavily infused with potassium channels. And so when you stimulate those opioid receptors, we're going to open the potassium channels. And because the potassium is positively charged, potassium will leave the cell. And because positive charges are leaving the neuron, that neuron becomes hyperpolarized. So it becomes more negative because it's lost the positive. And when it becomes more hyperpolarized, it's less likely to fire an action potential. Okay, so those are the two ways that opioid receptors work in order to decrease pain signaling. I hope that made sense. So blocking calcium channels reduces neurotransmitter release. Opening potassium channels causes hyperpolarization, and that action potential cannot be formed and transmitted down the rest of the second order neuron. So these are the three endogenous opioids that we give. When we give exogenous opioids like fentanyl, dilaudid, anything else with a methadone, it's going to stimulate these same receptors in the spinal cord. So that's our spinal analgesia. We also have these same receptors that are throughout the brain. They're not always involved in pain modulation. They do other things. Some of them are in our respiratory centers in our brainstem, which is why, especially like mu2, which is why when you give an extreme amount of opioids, you can have respiratory depression. A lot of them are involved in that reward pathway. So let me go back quickly to that reward pathway. Yeah, so they're a part of the reward pathway. Um, what's interesting about opioids here is that you see GABA here, which also an inhibitory neuron. Now, when it comes to dopaminergic signaling, there's always excitatory and inhibitory inputs. It's like a balance system, like kind of like a seesaw. And so you have an inhibitory inputs. And what opioids do, which is kind of interesting, is they inhibit the inhibitor. So by inhibiting the inhibitor, you're going to get an increase in excitation and an increase in release of dopamine and euphoria. So while opioids themselves don't directly cause euphoria, it's this indirect way of an inhibiting the inhibitor and getting that release in dopamine is why you can get euphoria when you give opioids. So that's kind of your supraspinal mechanisms. Why did I put these transitions in here? Okay. So that's down in the substantia gelatinosa. Very briefly about the endocannabinoid system. it really is involved in a lot of homeostatic mechanisms, not just pain, so appetite, metabolism, learning, memory, sleep, just normal parts of functioning. There's two main receptors, CB1 and CB2. So CB1 is mostly in the CNS, CB2 is more in the peripheral nervous system. And then you have two endogenous ligands that stimulate these cannabinoid receptors, so AEA and 2-AG. So we'll just mention that briefly. And then the gate control theory. So the gate control theory is what we have been talking about, which is this interneuron that acts as a gate to control the amount of signaling that goes to the brain. We talked about one mechanism, which is that descending pathway, but I briefly mentioned the other mechanism in the earlier part of this talk, which is about these A beta fibers. Now, remember I said that if you hurt yourself, you automatically want to rub that area or rub the skin in order to decrease the pain. And there's an actual mechanism behind this. And that's because your deep touch receptors or deep touch neurons, remember I told you the ones that were kind of encapsulated that looked like this, those are your A beta fibers. And A beta fibers are myelinated as well and a little bit larger than A delta neurons. And because they're larger, they're faster. Because they're faster, they actually get to the interneurons before the C fibers and A delta fibers, and they turn on those interneurons to decrease pain signaling, so that by the time that signal gets there from the C fiber or the A delta fiber, that interneuron is already working to decrease pain signaling. So that's the way how that's part of the gate control theory, why rubbing your arm kind of helps with that pain. Check the time here. So, all right. Yep, that's pretty much summarizing what we just talked about. For the second part here, we're going to just briefly talk about chronic pain and wrap things up. I'm just going to mention some pain therapeutics that are a little bit newer. But the next session that we have, which is going to be in July, is going to be all about going through the mechanisms of all those drugs. All right, so this is just going to be a little bit of an introduction. So everything that I've talked about before was just normal physiologic pain. That's normal, part of your body. Now we're going to talk about this transition between acute to chronic pain. And like I had mentioned, chronic pain is when you have pain that lasts more than 3 to 6 months. And this happens beyond normal tissue healing time. So tissue has already healed. There's no visible tissue damage. Chronic pain really has no protective function and really just leads to poor quality of life for people. But why does this occur? Um, like I mentioned, about 20% of people have chronic pain. What's interesting is the amount of money that goes into treating pain, chronic pain. 635 billion dollars. It's more than heart disease, diabetes, and cancer combined, is the amount of money that goes into treating chronic pain. It's actually unbelievable. And like I mentioned, people with substance use disorder, about 50% of those people have some kind of chronic pain condition. There's this cycle that goes along with chronic pain, which is really interesting. And I think, there's probably people in the audience that have experienced this as well. So you start to have pain. You start to avoid certain activities because it makes that pain worse. And so you stop doing things that you enjoy. You are still having pain, but now are starting to have negative feelings because you're not doing things that you enjoy. Your body becomes more tense and more painful because you're not using it. And then stress, depression, and fatigue start to set in. And now you're in this physical, emotional, and social state that makes the pain worse. And so you get stuck in this cycle. And I will say I have experienced this last year when I started developing chronic migraines. It was started to be a daily thing and an all day thing. And I would say that even I started to experience a pretty negative emotional state because I felt like I just couldn't do anything. And you start to feel like, is this my life now? Is this how I'm going to experience life every day? Is this ever going to go away? And it makes you depressed. And you can see how if you're going over, through this for years and years, how you can start to develop other types of comorbid disorders like depression and anxiety. So it's definitely a bad cycle to be in. Why does this happen? The main reason is that, you start with this central and peripheral sensitization. And that's when the neurons are more excitable. There's other cells in the central nervous system like glia, astrocytes that become reactive. You start to develop neuroinflammation. And over time, when your neurons are exposed to this type of stimuli for a long period of time, they start changing their structure, physically changing their structure. And we call this neuroplasticity. So even though neurons don't exactly, like when neurons die, they don't exactly regrow or reproduce, there are different parts of the neuron, like the dendrite, that will shrink or grow in order to increase the amount of synapses or decrease the amount of synapses with other neurons. That is a basic explanation for neuroplasticity. Your body is constantly undergoing changes in order to try to maintain some kind of homeostasis. But in this situation, it's not helpful. It's just causing more problems and causing this disease state. So, we call this neuroplasticity. These structural changes can be permanent, which causes these things to occur, central sensitization. What's interesting about central sensitization is that your brain will continue firing signals in these pain regions without any external input. So there's no signal coming from the body. There's no nociception, action potential coming up a second order neuron to the thalamus. There's none of that. None of that's occurring. But that neuron in there is structurally changed that it will fire and give you the experience that you're having pain when there's nothing going on in your body at all, which is really kind of terrible if you think about it, that your brain. And so people will often say, oh, well, it's all in their head. I mean, technically it is all in their head, but it's real. It's a real sensation that's happening that these neurons have changed. Um, so there's other things that go into it. A lot of these overlapping conditions, depression, anxiety, um, you know, different tissue morphology, microtrauma, and decrease in your parasympathetic tone. So you have constantly elevated blood pressure and heart rate as well. So that's kind of one of the main etiologies of chronic pain. This goes a little bit more into central sensitization, how those neurons become hyperexcitable over time. They'll fire even with no input at all. Neuroplasticity, so physical changes that happen in the brain neurons, and then hypersensitivity and spontaneous firing. So those neurons will spontaneously fire without any external input. Lots of different mechanisms that go into that. That's getting a little bit more into that. You can read that on your own. Very briefly, I want to talk about the biopsychosocial model. This is a theory that was proposed in the 1970s that still holds true today. And very recently, actually, I just posted today that me and another author that you might be familiar with, Edwin Oroki, just published a paper about this, about the connection between your psychological factors, your biological factors, and your social factors, so your environment, how that actually physically causes pain. And a lot of this is through epigenetics. Epigenetics is basically what controls what part of your DNA gets expressed and not expressed. And epigenetics can change based on your environment, based on your diet, based on your stress level, can inform whether your DNA gets translated or not. And so there's this really clear physical connection that we've been able to show with science between the way that you were rate trauma that you might have undergone and how those people are more susceptible to developing pain than other people. What's interesting also is that these epigenetic changes can be passed down through generations. You can undergo trauma in your generation, which will cause epigenetic changes to your DNA that you will pass down to your offspring. So even though your offspring might live a pretty stress-free life and not have the trauma that you experienced, they're more susceptible to developing chronic disease and chronic pain because of what you had experienced in your lifetime. This has been proven and shown through science, and a lot of this is supporting this biopsychosocial model. So it's not just the physical stuff. It's a lot of other things in our environment too that can make you more susceptible to developing this disease. Pretty interesting. I think we talked about that already, pain and substance use disorder. So just to wrap it up, let's just very briefly go over some of the pain therapeutics, and this is what we're going to focus on in our next session. Okay, some of our non-opioid therapies. So we talked already about the different types of therapies that are available: non-opioids, opioids, non-pharmacotherapies, and then those psychological therapies. There are quite a few, and for our next session, we're going to go through the mechanisms of action of each one of these topics here. One that I want to bring to your attention are that NaV 1.8 blockers. This actually just got FDA approved a couple months ago. So I wanted to tell you a little bit about that and make you aware because that's going to be coming down the pipeline. Other things that are still experimental, but things to be aware of is now we're looking at psychedelics as a treatment for pain, specifically psilocybin, which is the component of magic mushrooms. Also looking at some other drugs, which are kind of interesting. CGRP antagonists. Remember, CGRP is one of those excitatory neurotransmitters, and so we have some antagonists for that. BDNF, we'll talk about that, TNF alpha. Um, I had mentioned briefly that anticonvulsants are used a lot for chronic pain conditions, specifically gabapentinoids. Despite the name gabapentinoids, it actually doesn't work on GABA, it works on calcium channels. And remember, I talked about the presynaptic neuron. Those calcium channels control the release of neurotransmitter. There's a specific subunit on this calcium channel called the A2 delta subunit, and gabapentin works on that subunit to decrease the release of calcium, or decrease the opening of this channel and calcium going in, and decreasing the release of neurotransmitter. Unfortunately, despite us prescribing it like it is candy, it only works on about 30% of people, which is kind of sad and causes lots of side effects. People feel really kind of queasy on it, sedated, and it doesn't work that great. But everybody with any kind of neuropathic pain condition is on some kind of a gabapentinoid. You might see surgeons also prescribe gabapentin pre-surgery. I don't know if anybody has ever seen this, where the surgeons are giving your patients gabapentin pre-surgery. Okay, fine. I don't think it works that great, but that they're trying to just throw everything in the bucket and hopefully, hoping that people don't take as many opioids. And a lot of this is part of that ERAS protocol as well that you might see. Antidepressants. We talked about how SNRIs work. We have SSRIs and SNRIs. SSRIs don't really work. We really need the norepinephrine component, so it has to be SNRIs that work because we need to hit both of them. It can't just be the serotonin. So we need something like Cymbalta, which is an SNRI, which is a first-line therapy for many types of chronic pain conditions. So you see a lot of people on Cymbalta, but they don't have depression. Why is that? It's usually because they're using it as a pain therapeutic for these patients, and it's actually pretty effective, and it has very little side effects. Tricyclic antidepressants also block serotonin and norepinephrine, the main one being amitriptyline. I actually was on amitriptyline for my migraines for a while. It is very sedating, which is the main reason why I stopped it. Even despite taking it before bed, I would still feel groggy for most of the morning. So that's the main side effect with that. If you take it in really high doses, it can cause some cardiac problems. So that's the main thing with tricyclic antidepressants. And at one point, it was the main drug that was used for overdose was TCAs because of that cardiac and causing deadly cardiac arrhythmias. But we're using SNRIs more than TCAs now. I also want to mention the dose. Now, the dose is about a tenth of what we would use to prescribe to patients for depression. So if the normal dose would be around 100 milligrams for pain, it's about 10 milligrams. So the dose is a lot smaller. I'm not going to get into tramadol. We'll talk about tramadol in the next lecture. Tramadol, I think, is a dirty drug. Even though it works somewhat for pain, it works in a lot of other targets as well. It's not very specific, and it actually has some abuse liability as well. So it's not the best drug out there. I know we're still using it, but there's some issues associated with tramadol. We will talk a lot about ketamine when we talk about our next lecture, NMDA antagonists. But you might not have known that a lot of these other drugs have NMDA antagonist activity as well, specifically methadone. And that's actually a board question that comes up. You might be asked something about NMDA and antagonism, and it might say like pick all that apply, select all that apply. Methadone does have NMDA antagonist activity. Magnesium is something that we give as well to treat pain. It has several different mechanisms, but one of the mechanisms is that it blocks the pore of the NMDA receptor. So that's one of the ways that magnesium works. Some new or experimental therapies that are coming out. So we have our NaV 1.8 blockers, CGRPs. Those are new, experimental that I'd mentioned earlier. NaV 1.8. So this drug just got FDA approved a couple months ago, Journavx or suzetrigine. Right now it's only available PO. They're going to be starting to work on an IV formulation, and I really believe that this category of drug will eventually replace um, short-acting opioids for surgery. It is shown to work very well in treating acute pain, and because it doesn't act on sodium channels in the central nervous system and can't cross into the central nervous system, um, it has zero risk for respiratory depression or any kind of abuse liability at all. So it's pretty safe. This NaV 1.8 type of sodium channel is only found in pain neurons. It's not found in the heart. It's not found in any other parts of the body. It's very specific for just pain neurons. And that's why I think that this category of drugs is going to be the future for severe acute pain management. So no addictive potential. Some side effects, itching, muscle spasms, and rash, but I think those side effects are a lot better than the opioid side effects. So keep this one in mind for the future. CGRP antagonists. So CGRP was one of those excitatory neurotransmitters. CGRP sprays are now being used for migraine, especially for rescue migraine treatments coming out as a spray. It not only blocks pain signaling, but it also inhibits vasodilation and inflammation, which all contribute to migraine therapy or migraine diseases. Psychedelics, we talk a lot about this in the next lecture. It's kind of interesting that now we're looking at psilocybin for pain therapy. But basically, remember when I said chronic pain has to do with the synaptic remodeling of the neuroplasticity? The psychedelics actually kind of reverse that synaptic remodeling. So it's starting to look at it in right now headaches and cancer pain. Also looking at LSD. That's being studied right now. It's hard to study those things though because those drugs are illegal. That's just some kind of how we study synaptic remodeling. It's kind of interesting. We actually, in mice, we do this in our department. We put a window in the skull, and then we can microscope through that window over the course of several days. So this mouse like administers psilocybin, and then we watch these dendritic spines grow and shrink over the course of several days by taking continuous pictures of the brain of those dendrites. You can see some of these spines that are starting to grow as a result of psilocybin. And what's cool is that you can give one dose and those changes occur for several months afterwards. BDNF is a brain-derived neurotropic factor. It's a growth factor. And so this contributes to neuroplasticity. And so if you block BDNF, you actually decrease the development of chronic pain. Another factor is tumor necrosis factor. This is an inflammatory cytokine. A cytokine basically is a signaling molecule to cause inflammatory cells to come to that area. So it's causing pro-inflammatory cells to come to the area. So if we block TNF alpha, we're decreasing the amount of inflammation, that will eventually decrease the development of chronic pain. This is something that my thesis was about, what I have been working on. These are glutamate transporter modulators. So basically, glutamate, as soon as it gets released, it starts to get recycled back to the presynaptic neuron. And the way that it gets recycled is through these transporters here in the astrocyte. And so we developed new therapeutics to cause this transporter to work a lot faster, like a vacuum. cleans up all the glutamate in this area. So rather than blocking the NMDA receptor and causing all those kind of side effects with that, kind of maintains homeostasis by kind of rebalancing the glutamate in this area. So that's an area that I've been working on. Um, we actually developed this from a spider in Brazil. It's kind of disgusting spider. It's a Parawixia spider. They live in these like massive nests, as you can see here in Brazil. So we like collected the venom and purified it and figured out what molecule in that venom had those neuroprotective properties. And then once we figured out what that molecule was, we were able to synthesize it in that lab, make a couple generations of that medication, which got us down to our molecule that we're at now, Na14. So that's what I've been studying in animals. And that's what I did my PhD dissertation on, which was cool that I got to present this at the IASP neuropathic pain conference in 2023. That was in Portugal. It was an international conference. And nobody had ever heard of a CRNA before. I was the only nurse there. Everybody there that was there was either a neuroscientist or a neurosurgeon or an anesthesiologist, but people didn't know what a CRNA was. So it was really fun to tell a lot of these international people what a CRNA was. But that project, was one of 300 projects that got presented there, and our project got first place, which was pretty cool to represent nurses internationally. So it was a cool project. I'm happy that I got that opportunity. So that was a, overview of the pain pathway, physiologic pain, a little bit about chronic pain, and stay tuned for our next seminar, which is going to be the last Wednesday of July, which I believe, let me look at my calendar, is going to be July 30th. So we're going to go into all of those non-opioid therapeutics, going really deep into the mechanism of action and tying it back into what we learned about the pain pathway. So thank you guys. I know that was a little bit long, but hopefully you guys, it was a good overview for you. Definitely lots of references there. If you want to email me, let me know if you have any questions. And I'm happy to take questions now. I'll stay on. But have a great night, everyone, and thanks for listening. If you need the slides, let me know. I'll repost them. And otherwise, we're going to have the recording available via YouTube in 2 days. So I'll stay on if y'all have any questions about that lecture. And I hope it was helpful for you.